So here we also summarize the cases of intubation we have done. Actually, we have done about nearly 200 cases for the intubation. So, so for the PPE, most of them using the N95 mask, and also surgical mask, also goggles, and face shield. So using this PPE, no any personnel infected by the COVID-19. So this is a very good protection for our medical professionals during the intubation. Also, we check up we measure the hemodynamics during the intubation. Actually, most of the patients complicated with hypotension. So also complicated with the hypoxemia. So we think that the pre-oxygenation, so not enough for 5 minutes. So if possible, we prepare for longer time for the pre-oxygenation. Also, because almost half of the patients complicated with hypotension. So we suggest to give at least 250 ml bolus of fluid prior to the intubation. So also prepare the vasopressors to prevent hypotension. Also try to avoid the propofol, because propofol will inhibit the cardiovascular system. So this is our experience for the intubation. And also 5 patients died, complicated with the cardiac arrest during the intubation. So which indicated the hypoxemia, the management of hypoxemia is quite important during the procedure of the intubation. So here we emphasize that the hypoxemia and the circulation collapse probably happened during the intubation for the patients with the COVID-19. So we should be careful about that. So the last, I will briefly talk about the key points of the ventilation supports for the patients. So non-protective approach is extremely important for these patients. Prolong the patients as early as possible. So evaluate the modes, the parameters we set frequently. So switch or change if not appropriate. So titrate PEEP and the tidal volume based on the transpulmonary pressure, if possible, or driving pressure. Keep the driving pressure less than 15. Prevent acute cold pulmonary, which is always happened in the patient with the COVID-19. Also induced by the severe hypoxemia and subsequently severe pulmonary hypertension. So be careful of the lung recruitment maneuver. Set the highest PEEP at 20, because the high PEEP will induce pneumothorax for the patients. And also, we have the flow chart for the patients using the ventilation strategy. So based on the PEEP ratio, so if the PEEP ratio is 200 to 300, we can try high flow nasal cannulation. But here, I recommend the high flow used in the ICU environment designed with the negative pressure. So if the ICU environment without the negative pressure, probably the high flow will induce the pollution by the virus. And also we monitored the virus level in the different ICU environment. And also we found that we can find the positive virus in the air, in the surface of the ICU equipment, if without the negative pressure design. So we evaluate the efficacy for all the non-invasive ventilation based on the LOXI score. LOXI score is calculated from the respiratory rate, saturation, and also FiO2. So if the LOXI score more than 3 points, so we think that ventilation probably works. If less than 2.8, so we need to switch to another ventilation supports. So for the non-invasive ventilation, we should be careful about the BiPAP probably worsen the lung injury. So evaluate the tidal volume when you're using the non-invasive ventilation. So if the tidal volume less than 9 ml per kilo continue, if more than 12 intubated patients. So if the P4 ratio is less than 150, so we prefer intubation the patients. So also we need to evaluate the patient is response to the non-recruitment maneuver. So also if the driving pressure is quite high, we need to polarize the patients also with the prone position. And also we follow up the lung compliance. So if the patient's P4 ratio still low and also complicated with the acidosis and hypercapnia, and we need to switch to the ECMO for the patients. So actually here I also share a case report for you, but because you cannot see the PPT, it's difficult for me to show the case report. And I mean, the lessons we learned from this case. So it's if the non-invasive ventilation lasted longer time, probably would worsen the lung injury. So this lady received non-invasive ventilation in another hospital for almost 9 days, and when she came to our ICU, she is the severe.
No, I just wanted to know if you had things before, like fentanyl and or two.
Okay, so this patient, when she came to our ICU, she's extremely hypoxemia, and we intubated her, but only for a short time. Her condition become deteriorated, and then we switched to ECMO for her. So after 9 days of ECMO treatment, so she finally went off from the ECMO, and another 5 days, she finally went off from the ventilators. So here I summarized my talk. So the So the critical illness patients tend to be older with more comorbidities and laboratory abnormalities. So preparation of PPE and pragmatic protocol during the intubation is important to prevent transmission, prolonged pre-oxygenation, and the bolus of fluids, as well as the vessel pressures were required to prevent hypoxemia and circulatory collapse during intubation. So titrating the both parameters of ventilation support with non-protective approach is very important. The most common complications was ARDS, arrhythmia, and septic shock. Nearly half of the patients in our ICU required invasive ventilation.